Joan Harris, founder of Symphony Care Management, a life planning and concierge care management firm. And I have the honor and pleasure today of interviewing Johanna Brooks, nurse practitioner, and she is a nurse practitioner for the Palliative Care program at Good Shepherd Community Care. And I'm very excited to have a conversation with Johanna today so that people can learn about palliative care and how that is different from hospice care and how you access it and how it can be helpful in dealing with ongoing illnesses. So Johanna, thank you so much for being with us today. We're so glad to have you.
Thank you for having me.
And so I would love it if you could tell everyone a little bit about yourself and your journey to have this specialty and skill set in working with people who have chronic illnesses and in the palliative care program at Good Shepherd.
Sure. I've been with Good Shepherd for about a year and a half. And my journey here started, I'd like to say, I'm not even knowing that it started way back when I was in high school. I took a hospice volunteer training course. And my mother did a lot of hospice training, so it's kind of in the blood. And I did that in high school and loved it. And then I went away to college and majored in psychology and worked in the business world for many years. And then I became a nurse practitioner in 2017. I went to Regis, and I feel as if I found my niche with this work. I really love what I do. I first started when I first graduated from Regis. I worked with a different company and did some pediatric palliative care in people's homes, and I loved it. So then I got another job and got into the hospice part of it and transferred slowly a little bit into palliative care. Once I found Good Shepherd, that's where I really did the palliative care more full time. I started 4 days a week, and then soon after that, it was 5 days a week. So it's a really big, robust program, and I love being able to spend time with patients, sit with them, talk to them. It's why I went into nursing to begin with, to help people and to spend time. And I felt that in the hospital, I didn't get that.
Yeah, I think certainly post-COVID, we're seeing that even more, that staffing issues, and it can be a really tough environment, but it's just really different than community nursing. So I think what would be really great is if you could tell our viewers, what is palliative care? We hear that term in different environments. What is it? And then what is your community-based palliative care program? Tell us about that and the services you provide.
Sure. Palliative care is, we look at symptom management. We palliate, try to make better symptoms that anyone has as a result of a disease process that is going on. Palliative care is offered to anyone facing serious, life-threatening illness at any stage of that illness. And it doesn't matter if you are still wanting to seek curative treatments. We still work with patients seeking curative treatments. We work closely with physicians' offices and offer our recommendations for symptom management and really help navigate with the patients and help them on this journey. And it can be a long journey, and we can be by their sides for quite a bit of time. In the community, we go to people's homes, wherever they live, whether it be in their home, an assisted living, a memory unit, a skilled nursing facility. Mm-hmm. We go where the patients are, and we can follow them from one place to another. And our perspective is very unique in that we have time on our side, and we have this bird's eye view where we can, see things. We have episodic visits every couple of months, and we can really see changes that perhaps close family members won't see because they're seeing the patient every day and may not notice things. So we have that unique perspective. And we're in the patient's home. So we see how they're living, what's affecting them. And we're able to have really nice conversations and thoughtful conversations about what's to come and trying to anticipate some of them.
So when you say that you have time, I think it's really a good moment. We do a lot of education as care managers about that this is a benefit through insurance that people don't know they have to bring an expert in like you. Medicare covers it, other insurances cover it, and people don't know that's available. But there's a lot of misconceptions and myths about what is hospice and confusion about what's palliative care versus hospice. And so I think it would be really informative, and we do a lot of educating around this, how hospice is different, but how also in your journey with your patients, when and if it's appropriate, you know when somebody may be appropriate and can help bridge them to more services, different services like hospice. So if you could kind of talk about what hospice is and how it is different than palliative care, that would be great.
So hospice is a type of palliative care, but palliative care is not necessarily hospice. So in palliative care, we can still be seeking curative treatment, have therapies such as physical, occupational. We can take patients who are on dialysis, for instance, on palliative care. And sometimes people are eligible for hospice, but just not quite there. And that's
They're not ready.
Care can be appropriate then, right? We have that unique perspective and are in the home, so we can really follow patients and know when they do qualify for hospice. And that's based on specific Medicare guidelines. But once a patient is eligible, we let them know, they make a decision if they're ready or not, but then we talk about what the extra benefits are that you get on hospice. But when thinking of hospice, the difference between that and palliative care is that we're thinking that the patient we wouldn't be surprised with 6 months or less
life expectancy.
Right. 6 months or less of life expectancy, and shifting that focus, if you will, from quantity of life to quality of life, and really looking at dignity, comfort, and support of not only the patient but the family as well, which we do in palliative care. But that shift of focus and that thinking 6 months is not unexpected would be when hospice comes in. Hospice does offer some other hospice offers other benefits, such as a nurse that would come in weekly, if not more. We have a social work service. We have a chaplain service, and then different therapies like art therapy, pet therapy, Reiki, things like that. So there is a lot more support. They get durable medical equipment as well with hospice. And we also don't ever deny anyone whether they can pay or not, which is important.
And that's unique to Good Shepherd Community Care as a nonprofit. Is that correct?
Well, yes. So we are one of the few remaining nonprofit organizations left that just kind of work, and that enables us to prioritize the patients over profits, which is really amazing, and it does make a difference.
It's wonderful to stand in front of a mission-driven nonprofit. I've done that in my past, and knowing that you don't have to stop services if funding from either insurance or private stops. So that's amazing. That's really good for people to know. So it sounds like, from my standpoint, these are underutilized services, both of them. So we are often, as care managers, advocating and educating our clients to understand it's great to bring in someone like you early on, because it's a partnership that you build. It is quality of life. As you said, it could be over a long period of time, or that bridge to when we are really looking at end of life care, but to have your expertise to support them. So tell me a little bit more about the types of things that you're able to help with when you go in. We were talking about that a little bit before we started taping about, the types of skill set that you have and the types of things that you can actually affect when someone's dealing with a chronic illness.
Sure. So we can look at medications, things like that, and we can act as a liaison between patients and their physicians to give our recommendations. Sometimes we are looking at medications and removing things that aren't really absolutely necessary. If, for example, someone is having an issue with swallowing, we prioritize those medications. We remove things that they don't have to take. We really talk with families and ask those curious questions to try to get to know them, to see what's important and how can we help you on this journey. Talking with physicians, talking with care managers like yourself, talking with family members. And over time, we really get a pretty full view of what's important to these people, and have those really difficult conversations. I think the one thing that we all have in common is that we're all going to die, but it's the one thing that no one is really comfortable talking about.
That's right.
And it is so important to talk about these things. And we have ways that we can put things in writing and tell patients that, you can make a decision as to what you do want done or what you maybe don't want done in certain situations. So we can talk about advanced care planning, and we have the time to do that and really listen. And it's not over 1 hour or one visit. It's over the trajectory of knowing patients. And those things can change. So we can fill out most forms with patients, which are the medical orders for life-sustaining treatment, and talk about that. And we can change them. Sometimes, we change them every couple of months as things change with people's disease trajectory. I can also give you some examples of the kinds of patients that we see for palliative care. So we see people that, like I said, have life-limiting conditions. So people who have congestive heart failure, COPD, dementia, ALS. We have renal failure patients, liver failure patients, and AIDS. So those are some examples of the typical patients that we see. And the other thing is that we're not just there for when things are down, when things are not going well. We come for visits when things are going well, because you still need that emotional support. And so I'll talk about the anticipatory guidance, the things that are coming, even when there are good days, which we'd love to see. So it's not something that we come and see you because you're not feeling well all the time, or you need extra help all the time. It's that emotional support and that keeping that relationship going.
A little bit about how you assist people with comfort and pain management.
So of course, there's the pharmacological part of that, which we can be helpful with. And then also sometimes talking about complementary alternative medicine that can be helpful. Deep breathing, some meditation.
Do you refer people to massage therapy, or?
We refer people to Reiki, which is also something that we offer on the hospice side. But before hospice and palliative care, sure, I have said to some of my patients, I think Reiki might be something to consider. We can also help facilitate a relationship with not a chaplain that we have, but someone in the community. So whether it be a rabbi or a priest or a deacon, We also talk about what's in the particular communities. There's programs where seniors help other seniors. We can help tell you about Meals on Wheels programs. Talk about different agencies that can come in and help with care, to take the load off of that primary caregiver.
So those would be clients who don't, or your patients who don't have a care manager, who's doing. But it's wonderful to know, because not everyone has a care manager involved who's also putting together and coordinating those services. Not everybody is appropriate for care management, and you also work with people of what ages? You're not, are you working with pediatrics in palliative care?
We do have a separate PDPAL program.
Separate.
Specifically for pediatrics, and that's wonderful. There's no cost to that, and we have music therapists, art therapists that go in and work with children.
That's
in fact,
wonderful.
I met some of the Good Shepherd music and art therapists before I worked here because I worked in pediatric palliative care for a while. So I knew how amazing part of the team was before even joining, because I saw it right there in the home in action, and the difference that music can make for anyone, whether it's a child or an adult.
Yeah, it is unbelievable, and those are, I think, sometimes equally, if not more powerful than, medication management. It is important, and pain management with, pharmacologic remedies or medications are important, but it's really that balance of what is bringing that person joy in their life as well. And so you're looking at the whole person like we do. The client is centered, and by supporting the family, you are supporting your patient, because they're the ones who are often struggling. We have referred many clients of ours from Symphony Care Management to Good Shepherd Community Care, and we love collaborating with you. Tell us a little bit about working with people who have Alzheimer's or related dementias, because we've had that is a little bit different than some of the profiles you've talked about of the different disease states that you've worked with. We have many clients who aren't appropriate for hospice, but the lens that we're now looking at them through their own goals and their family is, how do we make them comfortable, and how do they live their best life with advancing neurocognitive diseases? So tell me a little bit about how you might work a little bit differently with somebody with a cognitive impairment disease.
First of all, the people that we see who have dementia and cognitive disease, I still sit right down next to them, look at them, talk to them. We do a lot of work behind the scenes with the family in those cases, but the patient is still our focus, no matter. And a lot of people will still, with dementia, will still communicate. We just need to give them that time they need. As a certified dementia practitioner, I also know that it takes a full minute sometimes for someone with a cognitive difficulties to answer. So if you're shooting questions at them one after the other, hi, Mr. Jones, how are you? Da, 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 da. By the time you're at your seventh question, Mr. Jones is saying, wait, I'm still working on how are you?
Yeah.
So we know, we work with them, sit there, we're patient, and we talk to them still in very much the same way.
Well, because people with memory disorders must be given the opportunity to participate to the best of their ability in their decision making and their care plan. So I love hearing that. It's completely how we operate as well. And as you get to know someone, people communicate in many different ways. And sometimes if they have more of a vascular dementia, they have more difficulty with word find versus, classic Alzheimer's dementia is going to manifest itself really differently. But coming into their world and their environment at home, I think also makes an enormous difference. And as you said, you're not under that 15-minute office visit time constraint. You're seeing their environment, which gives so many clues as to how things are going. And you can take the time, which I love. So as you get to know people, your recommendations are very much in line with what they need and probably what they want.
And we talk to the families also about any conversations that they have had in the past, maybe before the cognitive decline is where it's at now. We talk about the advanced care planning with healthcare proxies. Something I think is maybe worth mentioning. So before I started working at Good Shepherd, I had met one of my current colleagues. I was carrying my little chair. I have a small three-prong chair.
I know that little chair of yours.
Oh, you've seen it, yes.
Yeah.
You didn't see it once. Because I have been a patient myself. And I know what it feels like to be in that vulnerable position where you're already either sitting or lying in a bed. And to have someone standing over you and talking, it's just not going to work. So I sit right down next to my patients at their level and talk. And it's made a world of difference.
I love that.
I call it my communication chair because I've been told this patient is nonverbal. Well, an hour later, I come out of the room and we've had a very nice conversation. It just took a long time.
Yeah, but you're kind of going on an even plane. We don't sit on our clients' beds. That's their space. And so depending on where you're seeing someone, even in the home, if there's a lot of equipment, it can be kind of cluttered and there is no place for you to sit. So I love that because it's your nonverbal communication with them in your approach.
Nonverbal communication, we can work with families to explain how to receive those nonverbal cues. What are they? What are you looking for if your loved one can't say, I'm in pain?
Yeah.
Or I'm anxious. What kind of signs are we looking for? So we do that kind of work as well. And with the dementia patients, it's also important that we educate families about, if there's an outburst, if there's anger, if there's agitation, it's not directed towards you. It's directed to it's the situation. And we can try to mitigate the behaviors like that with sometimes with medications, sometimes with just a different approach.
Yeah, approach and strategy for them to back off. But also it is a lot of coaching around not reality orienting, trying to bring their loved one to their reality, but just kind of going with the flow. So it sounds like you have that education. You do a lot of that coaching with the family, which brings their stress level down. And if their stress level is lower because they feel like things are in place and they have a resource like you to reach out to, that reflects on their loved one. Because what we know is that people with dementing illnesses, they may not have the words, but they feel the emotions around them even more so. And so you're helping your patient when you're helping the caregiver in so many ways. Do you have any case in particular that you would like to talk about that might demonstrate your work in palliative care in the community?
Sure. So one person comes to mind. I see someone who has interstitial lung disease. And I've been seeing her since about April, following her in her home, giving support not only to her, but to her husband around the disease process and what to expect, and working slowly over time on the symptom management, and letting her know that this may be the time where you want to start considering taking this medication that could help with your breathing. But in the same sense, now we have to start working on a good bowel regimen, perhaps, that people aren't aware of once you're taking medication to help you breathe, should it be an opiate?
I mean, you're doing with this patient with the lung disease, you've built a relationship.
Yes.
So they're able to maybe, because I hear a lot of fear for people to take medication for symptom management. So if you have that relationship and you're doing the education kind of proactively, it sounds like, before they're, really feeling pain and uncomfortable, and it can be a snowball effect. You're helping with that education piece with medication management, and what other types of interventions with this particular case that are you able to provide?
With this particular case and the medication management, for instance, she had her oxycodone to help her breathing for probably a good 3 or 4 months before she decided to use it. And she decided to use it after we had another conversation when I came in, 8 weeks later, and saw there was a big difference in her breathing.
Yeah.
Really struggling more than I had seen before. So I said, this is probably the time where you can think about taking a very low dose of this, see if it works. So what we did is she took it at the beginning of my visit, and I'm there for an hour and a half. So we saw the effect of it right there.
Yeah.
And she had her Miralax in her water after she took it.
So it sounds to me like you were able to, provide that secure feeling and safety in that moment to take something that was a big step for her and whatever, and help her work through the fear of it. And then she could see, with less anxiety kind of flooding her, she could see the positive effects. So we know in the healthcare system, when people go to their doctor, if they're still able to, they're not getting that kind of time and continuity. It's more and more so on the patient portal site that they're communicating. They're not really talking to someone one-to-one anymore. So it's really hard to get that kind of support through no fault of the doctor, who's really stretched. They can't get this kind of support. And I think that's the message today for me, is through you, is for people to know that when you're dealing with disease that is significantly affecting your life, there is this palliative care benefit through Medicare, but other insurances for adults, don't have to be on Medicare, that's available to you, even a consult, because you and your patient can decide going forward what's going to be helpful. And so in our practice, people are just amazed that this is available. And we are bringing you, quite thankfully, to many of our clients and their families where their goal is to stay at home. And yet it is really tough on the caregiver. So I think you're a critical member of the team. They have their medical providers. So let me just ask you one other question. You come in and see a patient in their home, you see ways that you can help them with medication management. You then reach out to the physician, or is that between you and the patient or the patient's healthcare proxy to say, okay, I hear what you're saying, I'm going to reach out to the doctor? Or do you often reach out to the physician?
I can certainly reach out to physicians, and we do that often. Lots of physicians that refer to us, really, they want us on board because we're the eyes and ears in the home. We have the time. And a lot of the people that we see are no longer easily able to get out of the house and go to an appointment. And it is really a taxing effort for them. And so for us to come into the house is really a huge game changer. And many of the physicians will have a nice conversation together and we'll give our recommendations. And if not on board, we have a further conversation. Well, what else can we do? And we come up with some kind of solution or plan, put a plan in place together.
I think what people need to understand from this conversation is this is a lens, an expertise, a superpower, so to speak. We all have our superpowers, where you can look at your patients through this lens and know, when you assess them, the path of where they're heading and what needs to be in place and how things could be better. And you're communicating and you're educating. Every situation, every client, every family is unique and different. But what I'm hearing is that as physicians get to know what you do, they are respecting your lens and your expertise in this area, and they're looking for your insight because ultimately they, as you said, they can't be there and they want what's best for the patient. Is that?
That's, yes, you painted that picture well, yes.
Yeah, that's amazing. That's wonderful.
And it's privileged. It's really a privilege to be able to be in patients' homes and to help them on this journey.
Yeah, and it's a long journey. I mean, we have worked with Good Shepherd over the years, and to have you on a Zoom call or in-person family meeting with the assisted living, with the private care company, with the family, with us, and all sitting all together to really understand with the client in the central focus, what we all need to be doing in our different roles to benefit the patient. That's really what we want for our patients, right? We call them clients, is to have the people who have that expertise that we don't have so that their goals can be met. And in the cases that we bring to you, it really is about comfort and the best quality of life that they could have given whatever diagnosis that they have, whether or not it's cognitive or a physical diagnosis. Is there anything else that you would like people to know about palliative care services at Good Shepherd Community Care?
I think you had hit on it earlier, but I think getting the education out there about what we do, what services are available, because yes, people do often come on to service later than they're able to. I see that a lot in hospice, but with palliative care, like I said, we can still be seeing you while you're having curative treatments, while you are still going to the hospital and doing all those things. And it's that whole experience, that whole journey that we're on with the people. And it doesn't end when when things are getting better. Like I said, we still go, we give the emotional support, we still talk about the trajectory of things and how to anticipate what's coming. And it's I feel like it's we're just wrapping a blanket around them, really, giving them that.
I love that. So
space.
Sooner is better.
Yes, absolutely. Absolutely.
Yeah, and that's my motto as well. People don't know about care managers.
Right.
And so this is, I think, a service that we want people to know about so they can evaluate whether or not it's going to be helpful to them. And I would encourage anyone who's dealing with a chronic illness to reach out to Good Shepherd Community Care, which is a wonderful agency. In the community, you really build partnerships and benefit our clients. So we thank you for all the good work that you do with our clients. And as you said, making their journey better over sometimes many years. And we look forward to our continued work together and collaboration. And I want to thank you so much for participating today and getting the word out about palliative care services. Thank you so much.
Well, it's such a pleasure. I'm so glad that you asked and that we were able to do this, because it's such an important message. And the more people we can reach who can benefit from this, I think the better. So we continue to grow our program.
Which is wonderful. So if people do want these services, what would they do?
So we have referrals for palliative care that come from care managers like yourself. We also have them coming from physicians. But then sometimes we have a family member or a friend who said, oh, I knew someone who had Good Shepherd palliative care. I've heard how great it is. We've had an experience before. So a family member can call and request that. And then what we will do on the back end is reach out to the physician for that official referral. But anyone can request.
Anyone can call. So
yes.
Pick up the phone, call intake or
Yes, the main number for Good
The
Shepherd.
main number, and just ask for palliative care services.
Yes, for palliative care services, sure, and then we can start the process.
Wonderful. Excellent. That's great to know. Thank you so much, Johanna.
You're welcome. Thank you for having me.